Hey, good afternoon, good evening, or whatever time of day it happens to be, because we have registration from multiple places around the globe, the UK, South America, etc. I'm Joe Gallo from AnCan, and I'd like to just give you a quick, brief overview before we get started, and then we'll get into the program. Please make sure that you do keep your webcams and your microphones off. The webcams, if they end up showing up, will become distracting to the presentation. We're expecting quite a large attendee tonight. As you heard on that announcement, this is also going to be recorded, and it will be available via the on YouTube via the AnCan website. And I think that's pretty much all that I have to say here, except now to give you the information, the standard legal blurb. And as soon as this pops up. Okay. Just want you to be aware that any information, opinions, or anything else expressed in this presentation, either by the doctor or anyone else in the organization, is not to be intended as a recommendation by AnCan or any of its representatives for any medical treatment, product, or any course of action. You should always contact your doctor to discuss anything that you'd like to pursue. And if the next slide would like to come up, we'll be in good shape. Okay, and here we just get an opportunity to thank our sponsors. Our primary commercial sponsors are Myovant Sciences, Pfizer, Foundation Medicine, and Advanced Accelerator Applications. You'll also see listed there the other groups that we are associated with that partner with us in sharing this information around. Zero, PCAI, ASPE, Prostate Cancer Support in Canada, and the Walnut Foundation. And with that, I will turn it over to Rick Davis to do the welcome.
So, Happy New Year, everybody. Delighted to have everybody on board. This is the last of, I think we've done 12 webinars this year, of which about half have been around prostate cancer. Hopefully we'll be doing much the same. And we are really delighted to have Dr. Kirsten Greene with us, who I have known, even though she hasn't really known me, for about 11 years or 12 years. And I've been sending patients to her for that long. She doesn't know that either. But it's just a thrill and an honor to have her. And we both share UCSF in that that's where Dr. Greene learned her trade from the very best in the business, and that's where I got treated by the very best in the business. So with that said, again, Happy New Year to everybody, and enjoy the webinar, and we'll see you in one of our webinars in 2022.
And with that, we'll turn it over to Howard Walensky, who will be our host for this evening.
Yeah, no drinks, not serving tonight. Except for Peter Monaco. At any rate, welcome. It's been another year, another weird year. Hopefully next year will be better. And maybe active surveillance has been the calmest part of this year. Who knows? But all of us who have gone on active surveillance or are considering it or are considering leaving active surveillance face major questions. And we're lucky tonight to have Dr. Greene, who can address both ends of the rainbow, those who are considering entering active surveillance and those who are considering leaving active surveillance. Let me tell you a little bit about Dr. Greene. She's chairman of the University of Virginia's Department of Urology, and associate chief medical officer for the University of Virginia Health. Her clinical interests include urological cancer outcomes, screening, quality of life, minimally invasive surgery, and novel imaging technology. She has served as a member of the American Urological Association's Guidelines Committee and helped create guidelines on prostate cancer screening and treatment. She earned her MD from Johns Hopkins in 2000. She had her internship and residency at University of California, San Francisco, as Rick said. She moved up the ladders there to full professorship by 2018. And she left for the University of Virginia in 2018, where she was named chair in urology in 2019. And for her, that was a homecoming because she had an undergraduate degree from the University of Virginia. So, Dr. Greene, the floor is yours.
Howard?
Yeah.
Before you start, I just wanted to pop up a quick polls that'll give us a perspective on who's attending.
Okay, great.
Okay, so hold on one second. Let's get this one here. So I'd appreciate if everyone would please respond to the poll. I'll leave it up there for about a minute. This will give all of us, including our presenter, Dr. Greene, an idea of what level the audience currently is. I'm watching. It looks like we're about 1 or 2 people trying to still put it in. Okay. And if I remember how I do all this, I will then show you the results. Oh, that was not good. I went away.
All the suspense, I can't wait. I can't wait to see it.
Yeah, well, unfortunately, what happened is something happened to my screen. So,
I mean, I can read it.
well, go ahead if you would, please.
Okay, it looks like 90% of people responded. 18% have been on active surveillance for 1 year or less. 39% have been on for 1 to 5 years, and 30% have been on for 5 years or more. 4% have progressed from active surveillance, and 9% were never on active surveillance. And I should point out, in submitting questions, our main focus is on active surveillance, but we're totally open to questions about anything from anyone, especially generalized questions. So feel free to submit the questions. Dr. Greene will answer them, although we're not going to give you personal medical advice. At least we'll try not to. Anyway, Dr. Greene, should we try it again?
Sure. Should I share my screen now, or are you going to try to show the poll one more time?
You can go ahead. You should be able to go.
Okay, great. I want to thank you all so much for having me this evening, and I'm going to try to share my screen right now. You guys see it?
Yes.
Awesome. All right, we're going to start from the beginning. And again, I am talking about, sorry, I'm just getting this fixed. How do you know when to enter active surveillance, and how do you know when to leave? So a couple just basics to get started. Active surveillance is not watchful waiting, and I think that's a really important point because some people use the two interchangeably. Active surveillance itself involves really close PSA follow-up, serial biopsies, MRIs, maybe genomic testing, depending upon how you feel about it and how your physician feels about it. The goal, I think, is what makes it really different. You know, the goal of active surveillance is to safely delay treatment, but preserve your option to still be treated for cure. And I think that's where things are really different from watchful waiting, of course. Watchful waiting is hands-off. You know, you check your PSA periodically, you're not getting biopsies, you're not getting any additional imaging, and the goal is completely different. It's really to allow the prostate cancer to take its course, which means it may spread, and to treat the symptoms when they arise, but there's not a plan for curative treatment. And anyone who's out there who's been a patient of mine knows I'm always really clear about this point, because active surveillance is about timing of treatment. Watchful waiting means you are never planning to be treated. And I think as a patient, my recommendation, I'll make a couple of recommendations as we go. You and your physician both need to know if you're on active surveillance or if you're on watchful waiting. And it should be the one that you want. They're not synonyms, and they have completely different destinations. You know, it's like when you get on the plane, you think you're going to Hawaii and you're going to Charlottesville, for example, or Detroit. You got to know where you're going. And I feel like active surveillance really is a destination, and you need to make sure that's where you want to be. So the goals, again, active surveillance, you're either avoiding or in almost every case, delaying the costs, the functional costs, the sexual function, the urinary function, or the financial cost of treatment without compromising cancer cure. And that's what's really important. This is compliant with all screening and treatment guidelines currently available. And I'm going to go over those a little bit. Active surveillance is based on the rationale, and this is so important, the rationale that the initial assessment is accurate, meaning that first biopsy, that MRI, your PSA, that's all representing what's actually going on in the prostate. And that monitoring is accurate and is going to identify subclinical progression at a time when you can still have the same treatment options and still be cured. Again, it's about timing of treatment. In most cases, it's not about delaying treatment forever. And active surveillance itself is not a treatment. It's an option, but it's not curative in and of itself. So why do it at all? Low and very low risk prostate cancer is not life-threatening at the time of diagnosis, as long as we are right about the diagnosis, going back to the accuracy of diagnosis. Active surveillance is about preserving your function, your urinary function, your sexual function, bowel function, and for some men, it's about preserving fertility. The goal, again, is to allow for curative treatment with equivalent outcomes when surveillance is ended. So active surveillance is also about prioritizing your quality of life. And then generally speaking, active surveillance is going to vary a little bit from person to person and practice to practice, but at its very core, you're getting PSA testing every 6 months. Now, some people do it every 3 months. I have some patients who have really variable PSA, and sometimes it's just nice to be able to check it a little more often. But 6 months intervals is kind of standard practice. Repeat biopsy at 1 to 2 years, and I think this is a key point I'd like to talk a little bit about more later. Digital rectal exam maybe once a year. MRI and genomic profiling for your initial risk assessment and to allow for targeted biopsy. MRI fusion biopsy is now the best way. It's pretty much standard care for targeting prostate biopsies and increasing accuracy. And treatment is considered, you know, when to end active surveillance, it's when you have a change in grade or volume of disease or both. I want to say a few words about PSA density because I think this can be very helpful to patients, especially with a variable PSA or patients who have a really large prostate. So this is a little bit of data just to show that PSA itself is not as good at predicting treatment or reclassification, meaning biopsy progression like upgrading, than PSA density. And the PSA density that we worry about, of course, is anything that is greater than or equal to 0.15 or 15 cents essentially. So a PSA density that's higher is actually predictive of biopsy upgrading in the future. And I think it's just another piece of information that's important for patients to know and be able to track over time. You know, if your prostate is shrinking, let's say you're on finasteride dutasteride, and your PSA is going up, that means your PSA density is going in the wrong direction. And that is prognostic in and of itself as well. And of course, PSA density is your PSA number divided by the size of your prostate. So these are NCCN guidelines. These are the new ones, and I'll just go over this very briefly. Just showing the different risk groups, because in prostate cancer, the risk group is more important than any one variable. And so your risk group or your risk category is your stage, your grade group, which is Gleason 3+3 is grade group 1, your PSA being less than 10. The volume of disease is really important. How many prostate biopsies have cancer in them? And then PSA density is there as well. Low risk is the same as very low risk, but doesn't really have a limit on the number of cores. And then intermediate risk on NCCN guidelines is different from the AUA guidelines, which is about to change. Intermediate risk could be Gleason 3+3, or it could be Gleason 3+4. And it has more to do, favorable intermediate especially, has more to do with the volume of prostate biopsy cores involved. And this is high risk or very high risk, which are not reasonable for active surveillance. Could be reasonable for watchful waiting, but not for active surveillance. Now, active surveillance is the preferred treatment option for very low risk patients by NCCN. And you can see that's the very first line. So this is what people with a good life expectancy over 20 years or 10 to 20 years should be doing. This is the right course of action. And the low risk group, this was a huge controversy just recently. I'm sure many of the people listening are aware of this. Initially, when these guidelines came out, active surveillance was not indicated as the preferred. The low risk group, and this is a group of men with Gleason 3+3, grade group 1 prostate cancer, low grade, low PSA density, but any volume of disease. NCCN recently updated this. And again, active surveillance, thankfully, is the preferred approach for these patients. So thank goodness that was changed, but still active surveillance preferred for low risk prostate cancer patients. And then favorable intermediate group, I like to point this out because favorable intermediate by NCCN is still men with grade group 1, Gleason 3+3, but it's people with a higher volume of disease. And active surveillance is still an option in these patients as well. And this can also be people with a little Gleason 3+4 disease too, which I'll talk more about later. So still active surveillance is considered, but not preferred. And the AUA prostate cancer guidelines are about to change. They should be released soon, but just showing, again, very low risk prostate cancer, active surveillance, strong recommendation, and for low risk active surveillance is also a recommendation with moderate strength based upon publications. Intermediate risk, again, favorable and unfavorable. By AUA guidelines, favorable intermediate is Gleason 3+4 or grade group 2. Active surveillance is a possible consideration for those men as well. And again, I'm going to address that a little bit more later. And then risk stratification for high risk, active surveillance is not recommended in this group. So recommendation 2, you should know your risk category, either by NCCN or by AUA, one or both. But I think as a patient, it's important, number 1, absolutely know, are you doing active surveillance or watchful waiting? And number 2, know what your risk category is, because you should be able to take a look at these guidelines as well and feel like you can look at the different categories and see how you might change going across them. The other reason I think this is really important is, if you're favorable intermediate risk, but you're thinking you're very low risk, that might be just a very different situation. You need to know what your own risk tolerance is, but you also need to know where you fall. So who are candidates for active surveillance? NCCN, very low risk, absolutely, low risk, and some people in the intermediate risk group. So who in the intermediate risk group? Low volume secondary pattern 4, so Gleason 3+4 with a small amount of pattern 4, no cribiform and no introductal pattern, which have evolved over time to be much more concerning patterns of 4, even meaning if you have a small volume of pattern 4, but it's cribiform, potentially active surveillance is not the best idea. So going back to the goals, it's about avoiding or delaying the costs, again, functional, monetary, of treatment without compromising cancer cure. And that's why we have to think really cautiously about the intermediate risk patients. It's based on the rationale that the initial assessment is accurate, meaning that first biopsy didn't miss something, and that the monitoring that you're having is accurate and it's going to let you know when you're experiencing progression at a time when you can still achieve a cure. So I'm going to say this throughout the talk, but active surveillance is about timing of treatment. It's not about never being treated necessarily. So triggers for intervention. I think this is an important consideration for everyone. A lot of times it can be a consistent change in PSA kinetics, meaning your PSA is rising consistently. It's above 10. We cannot otherwise determine it. Progression on follow-up biopsy, progression meaning grade progression, so upgrading to 3+4 or a higher grade group, or progression to a higher volume of disease. Patient anxiety, I think patients don't really talk about this, at least to physicians, a lot. I think sometimes it can almost feel like you're giving up on active surveillance as a patient because you're just tired of it and it's starting to weigh on your mind and it's taking away your quality of life. So if you're out there and you feel like this, you're not alone. About a third of people leave active surveillance just because of the anxiety component. Certainly clinical or radiographic evidence of progression, meaning if all of a sudden you have any evidence of extracapsular extent or concern for seminal vesicle invasion, I would say time to leave active surveillance. And then, as I mentioned before, if there's any cribiform or intraductal, I don't recommend surveillance for that. And I think remembering that it's about the timing of treatment, and you want to know when the time comes that it's no longer safe. You know, if you see any of these things happening, that might be evidence for you that the time has come. So current controversies, what risk categories are appropriate? We talked about very low, low, no questions there. Favorable, intermediate really is controversial. Is it safe for African American men? Some men are told they're not candidates based only on race. Is it okay for younger men? You know, are they appropriate candidates as well? So here is an article from Journal of Clinical Oncology, JCO, and it was looking at active surveillance in younger men, 3- and 5-year upgrade-free survival rates. And if you see this, the men under 60 are the blue line, and it's presented a little bit funny. It's upgrade-free survival, meaning how many people stayed on surveillance. And younger men actually progress more slowly. I put this up because sometimes I'll have a patient and he and his family feel like, look, you know, low risk cancer, but I can tolerate this better now. You know, I'll get through surgery better now because I'm young. And the contrast to that is saying you're young and you have a great quality of life that's so important to preserve. And your cancer, at least there's some evidence that it's going to progress more slowly. So that's a reason why, yes, you're young and you've been diagnosed with cancer, but active surveillance may actually give you so many years of a great quality of life, but still affords you an equivalent chance of cure. So consider active surveillance. The question of whether African American men are able to have active surveillance as an option at all, I think is an important question because race is associated with death from prostate cancer, with worse outcomes. And I want to show you 3 different articles that show that this is safe among African American men and absolutely should be offered and not withheld, simply because race is associated in some cases with higher risk disease. So the first study is from UCSF looking at the CAPTURE database, and it actually showed that African American race was not associated with upgrade or upstage. Now, there weren't that many men who were African American versus other races in this cohort, but it actually did not show any worse outcomes with very close follow-up in that group. And the search database, which is the lower box here, again showed no significant association with race or pathologic upgrade or upstage or positive surgical margins. And these men, again, remained on very close follow-up. It certainly wasn't associated with risk of biochemical recurrence after radical prostatectomy. So these are 2 examples of studies showing it absolutely was safe. This is information from a JAMA article from 2020, and this is a great article because it had a large number of African American men included, followed them for a very long time in the VA healthcare system, which meant an equal access healthcare system. And what it found, I think, is very interesting. So first, African American men did show more prostate cancer progression while on active surveillance. But at 2 years, it wasn't any different. which means that if someone is going to preserve quality of life for 2 years and it's valuable for him to be on active surveillance, it's completely safe. The next point I want to make is if you take a look at the next arrow, that line indicates when 50% of men had disease progression. It took 8 years to reach that level. And that's a very slow progression. It was faster than the cohort, the yellow line, which showed non-Hispanic white men. But still, I mean, 8 or 9 years for people to even reach a 50% mark, that's a lot of men who got to enjoy active surveillance safely for a very long time. And then the second one was cumulative definitive treatment. That one's, I think, a little bit harder to really quantify because sometimes a physician could recommend treatment and could take into account race, whereas the progression, I think, is a little bit cleaner analysis. Now, importantly, same study, JAMA study, it showed no difference in metastasis and no difference in dying of prostate cancer for these men, which are the most important outcomes, right? Active surveillance is about delaying your treatment, but still having the same chance of cure. And that's exactly what this study found. These are some other really important points from that article. And I hope I'm making the case that active surveillance is safe and should not be withheld from men as an option. So 40% of men in that group in that JAMA article avoided unnecessary treatment by 10 years, meaning 40% of men by 10 years were still on active surveillance safely with no upgrading and no treatment. Yes, closer follow-up might be needed. African American men may be at higher risk of progression, but this just means that, you know, good PSA follow-up, good MRI, good accurate biopsy. These are doable. These are tenets. These are the hallmarks of active surveillance. Time on active surveillance may be shorter than other races, but even the JAMA article is the same for the first 2 years. So I think those 3 studies I showed you prove that race should not exclude a man who has very low or low risk prostate cancer and is interested in active surveillance. So this should be an option for everyone. These are 5-year outcomes from the sort of the 5 biggest active surveillance groups, showing treatment is about 1/3 for most people in the first 5 years, and biopsy reclassification can vary pretty widely from 28% to 49%. So different cohorts are going to behave a little bit differently. This is again looking at upgrading, biopsy upgrades on the left, treatments on the right. You can see years from diagnosis goes all the way out to 10 years, and none of these cohorts hit a 50% cumulative probability of treatment by 10 years. So it is doable to stay on active surveillance for a long period of time. Results from one group may not be applicable to another. Having biopsies done every 2 years compared to annual is going to delay timing of progression potentially. And then this is from a more recent evaluation of the Hopkins cohort, which is considered to be one of the strictest cohorts for keeping very low risk men only. One thing I thought was very interesting in this is a very, very busy slide, but the one thing that was protective against biopsy reclassification, which means upgrading, was having a pre-enrollment MRI, which I think is really important because it's not relying just on biopsy and transrectal ultrasound alone, but if you have an MRI, that actually was associated with less upgrading. So I think, and I'm going to mention this in a few slides, imaging is a really important part of active surveillance and should be included. I'm going to just stop for a second and say a few words about prostate biopsy, because this is the worst part about active surveillance for so many patients. And I know a lot of people really want to avoid it and want to do anything else but a biopsy. But I want to kind of make the point, this is the most powerful tool we have on active surveillance because it tells you your risk category. The Gleason grade, the grade group, it could be used for genomics, having that actual tissue sample. It tells you the volume of disease, the grade of disease. It tells you if there's any cribriform, if there's any intraductal. So it is so important. So yes, for me, for my patients, I think it's really critical that you have to have repeat biopsies. And if you don't want to have repeat biopsies, I think you should strongly think about whether surveillance is right for you. My opinion is that you should have anterior cores sampled as well. This is something that we were taught at UCSF, and so it is a little bit of a regional variation. It's not the same everywhere. But 20% of newly diagnosed prostate cancer, or 20% of men with newly diagnosed prostate cancer have disease in the anterior zone of the prostate. It's not routinely biopsied. It can hide there, and it will make your initial risk assessment wrong because you haven't even biopsied that area. So that's my 2 cents about active surveillance and anterior cores. So who should consider active surveillance? Absolute requirements. You have to know what you're getting into. You have to know what's involved, the risks of doing it, why you are doing this. Remember, even in very low risk men, the risk of metastatic disease over time, it's 1 to 2%. It's not zero. It's incredibly low, but there is a small risk that, the cancer will progress, or more likely that there was worse cancer there than we realized. Maybe you didn't sample anterior cores, maybe you didn't get MRIs. So there is a small risk. You have to have someone to follow up with regularly. I just don't recommend that anyone just goes this alone. You need someone, no matter where they are, a physician or an APP or someone to follow along with you, to order the right tests, to talk with you about your concerns. I think it's important as a patient to be willing to follow the protocol, meaning, yes, get the biopsy, do the imaging, do your PSA testing, and then understand ultimately it is about delaying treatment. It's not likely going to be about avoiding treatment in your lifetime, maybe unless you have very low risk prostate cancer. And then this last point, I think, is the hardest point. You have to know what your risk tolerance is. And some people, just the idea of knowing they have prostate cancer and not doing anything about it, it consumes all their thoughts, and it really hurts quality of life. So you have to know your own risk tolerance. And if this is not something that you feel like you're comfortable with, it's okay. You don't have to do this. It's an option. Just because it's a preferred option doesn't mean anyone is going to force you to do active surveillance if you don't want to, or if you don't want to take that 1 to 2% risk. Now I'm just going to say a few words about serial imaging during surveillance. And this is really MRI. This is just an example of a PIRADS5 lesion, and this MRI in and of itself can actually predict upgrading or upstaging in the future. PIRADS4 or 5 is a predictor of progression and adverse pathology. And I want to just say for a moment, a PIRADS4 or 5 lesion does correspond with higher grade disease, so Gleason 7 or above, but it's not diagnostic of Gleason 7 or above disease. Only a tissue sample can diagnose that, and you can have Gleason 3+3 or grade group 1 disease in a PIRADS5 lesion. So they are associated, but they're not diagnostic. I think it's important to have an MRI during the first year of diagnosis. If you didn't have it before that, diagnostic biopsy, and it's certainly recommended by the NCCN. It really just helps you see what is not well seen on transrectal ultrasound, and it's a double check. It's making sure we didn't miss the lesion or miss a more important lesion. It's great for evaluating anterior tumors, and that's what the little arrows are pointing to. That's an anterior tumor. The back of the prostate is what just usually gets biopsied. The anterior zone, 20% of the time, there's going to be cancer there. And again, another reason why the MRI is so important is that the whole point of active surveillance is that we think we know what you have. We think the initial diagnosis is accurate. And if it's not, then we need to be able to tell you and make an alternate plan. So MRI is super important. Concerns with this, certainly cost. Insurance doesn't cover it everywhere. There's variability in terms of interpretation, meaning it's a difficult study to read. You have to know the different phases. You need to have a 3T magnet for it to be really good. Access to this is not the same for everyone, everywhere you live. And it can miss some cancers. It's not 100% accurate. You can integrate this with other markers like Psa Density, 5, 4K, and sort of decide when to use MRI, when to use other things. But it is an important element of active surveillance. This is just showing you, this is some work from UCSF, and I like to put this in here because it shows you the utility of one of the genomic tests versus the utility of prostate PIRADS4 or 5 disease. And so what essentially this is showing you is the positive predictive value by year 5 of different GPS levels, that's the Oncotype test, versus the PIRADS5 versus the PIRADS1, 2, 3. So you can see they're both very useful. And I show this because let's say you can't have an MRI or you just don't have access to it. potentially having a really high GPS score or having a really bad Decipher score or any one of these markers could be something you could use instead of MRI if you just don't have access to that, and vice versa. So what about Gleason 3+4? Can men with 3+4 still stay on active surveillance or be on active surveillance? The answer is yes, in some cases. Risk profiling used to just be grade and volume of disease. And now we have so many more things in our armamentarium, volume of disease, PSA density, what's your PIRED score? Did you have a fusion biopsy or not? What about the genomics and multivariable risk models to predict likelihood of progression or likelihood of survival after surgery or radiation? So this is, again, some data from my former colleagues at UCSF, and it's just looking at treatment-free survival during active surveillance. The blue line is Gleason 3+3, and the yellow line is Gleason 3+4. And so, as you can see, over time, men with just Gleason 3+3, grade group 1, they stayed on surveillance more than the Gleason 3+4 cohort. Okay, so that just means that they were advised to get treatment and got treated, right? Now, this is taking a look at biochemical recurrence for this group after delayed radical prostatectomy. The blue line is just 3+3, that's the reference group. The middle line with the arrow is Gleason 3+4 in one core only, and it's really, really similar to Gleason 3+3. The yellow line, the bottom line, is Gleason 3+4 in 2 cores only, so worse, and statistically significantly worse. So this leads me to my first consideration for men with Gleason 3+4, grade group 2, seems to be safe if it's very low volume, maybe 1 core, maybe 2 cores if it's very low volume in each. Prostate cancer specific survival was 100%. Metastasis-free survival was very, very low as well, or very good as well. Very few metastases. These are some preoperative predictors, and it was taking a look, taking a multivariable model, taking a look at Gleason 3+4 and 2 cores versus 3+3. And so that was statistically significantly worse. Gleason 3+4 with 1 core and versus Gleason 3+3 was really no different. So that again leads to my recommendation that if it's just in 1 core, it seems to be equal to just grade group 1 Gleason 3+3 disease. Now, a few words of caution, and what I mean by caution is probably don't do active surveillance if you have this. Very high PSA density that's unexplained. We don't know why. My concern is we're missing something. PIRED's 4-5, not a reason not to do active surveillance. Adverse genomics, maybe in and of itself, if it's the one outlier, I wouldn't not do active surveillance. But cribriform histology, intraductal histology, both have much more aggressive behavior. And what we worry about with that is that it metastasizes. So we don't want your prostate cancer to spread on active surveillance. And the larger number of biopsy cores of Gleason 3+4, so meaning, do you have 3 cores with a 4 component in it? Do you have 4 cores with a 4 component? I probably would not recommend active surveillance for those cases. So what to choose for active surveillance? If you have high volume of Gleason 3+4 with bad genomics, extracapsular extent or seminal vesicle invasion on imaging or cribriform pattern, get treated. Immediate treatment, meaning not active surveillance, not a rush to treatment. But if you are in poor health, watchful waiting is probably the right thing because prostate cancer has such a long timeline. In terms of people who maybe could have less intense active surveillance, if you have a really low PSA density, if you have a lot of negative biopsies, really favorable MRI and genomics, maybe those are cases where you really are delaying biopsies, not just 2 to 3 years, but maybe you're delaying them longer if everything else is held stable. Again, remember PSA density versus PSA, it's a better predictor of treatment and reclassification. So it's another important thing for you guys to consider. Paradigms are really changing. We used to want to detect all prostate cancer and treat all prostate cancer. That was like the 90s and the 2000s. Detect all and just treat some of them. That's where I think we've been for a long time, and active surveillance is really helping with this. In the future, hopefully, we're going to detect just the ones that are important and treat the ones that we need to treat, but not overdiagnose so many men. Maybe not put people who are very low risk on active surveillance because they didn't have to be detected at all. So what I was asked to talk about was, when should you stop active surveillance? Talked a little bit about when we should enter active surveillance. So I just want to say, first of all, active surveillance, do you have to stop? No, you don't have to stop just because you think you're healthy and can tolerate treatment better. The opposite is actually true as well. You're healthy, and so you probably have a better quality of life, and you're going to enjoy the years on active surveillance more because you have a great quality of life right now and you want to preserve it. You're young, so you feel like you have to stop. No, you don't have to stop because you're young. As I showed you, there are studies that show that cancer progresses more slowly in men who are under 65. And if you're African American, this shouldn't be offered to you or you shouldn't have it. No, that is entirely wrong. With good, close follow-up, just like anyone else, the outcomes are equivalent. Maybe the time on active surveillance is shorter, but that doesn't mean you shouldn't be able to enjoy a great quality of life in that time and still be treated for cure when it's the right time. Okay, active surveillance. You may want to stop. Kind of a yellow light here. If your urinary symptoms are so bothersome that you are going to need surgical treatment for this anyway, some men at that point say, look, I want surgery specifically. I know I'm going to choose that and not radiation. Maybe this is a reasonable time to proceed with definitive treatment for prostate cancer as well. Now that's kind of a soft call because certainly you could just have a TURP and stay on active surveillance for a lot longer, or resume, or UroLift, or whole EP, or anything else. But it's a maybe. You can't have an MRI because you've had a new pacemaker placed or some other device that doesn't allow you to have an MRI. Now, this isn't critical. There are other things you can do. But if you're on the borderline, let's say you have intermediate risk prostate cancer, either due to Gleason 3+4 or maybe due to a really high volume of 3+3, you have to think about, are you willing to stay on active surveillance without the possibility of doing an MRI? A really good transrectal ultrasound can take the place of this if you have a physician who's very good at transrectal ultrasound. If you can't, or you just won't have another prostate biopsy for any reason, you may want to stop active surveillance because it is a really important part of surveillance, or you may decide that watchful waiting is the way that you want to go. But again, if you're at the point in surveillance where maybe you're going to need treatment kind of soon, maybe this is a reason to go ahead and get treated because you just don't want more biopsies. And then certainly some patients who are being evaluated for organ transplant, it is helpful to get definitive treatment if you potentially are in the intermediate risk category as well, just to help that transplant consideration move forward. And then active surveillance, red light, absolutely you should stop. When you have increasing volume of disease, like significantly increasing volume of disease, in my opinion, if you have a rising PSA which is not explained, and in the back of my mind, I'm always worried that there's an anterior tumor or a periurethral tumor that's just not getting biopsied. If you have upgrading, so all of a sudden, 3+3 to higher volume 3+4, if you have an increase in stage on imaging, meaning there's extracapsular extent, there's seminal vesicle invasion, cribriform intraductal, as I mentioned already, or then if the psychological stress is really worsening your quality of life to the point that the active surveillance is taking away all the good things that it was supposed to provide, that's a reason to stop active surveillance as well. So this is just a quick summary. It is absolutely safe in well-selected patients, but it's a commitment. It's a commitment between you and your physician that you need to follow this closely together. Safe in very low-risk patients, there's long-term data for this, there's no question. In select patients with Gleason 3+4, meaning grade group 2 disease, you can be a candidate for active surveillance as long as MRI is favorable, PSA density is low, genomics are looking good, low volume disease. Again, I showed you some data. My preference is like 1 core. It's delaying treatment for a few years. It's not delaying treatment forever, but that's not to say that a few years of delaying definitive treatment isn't worth it. As I said multiple times, active surveillance is not about avoiding treatment necessarily. It's about safely delaying treatment for as long as you can and as long as you want to. I think this is a great opportunity for someone to improve overall health while on surveillance, because remember, this can improve your long-term survival. The #1 killer of American men is not prostate cancer, it's heart disease. So this is a great time to make your health better in every possible way, and also things that will help you stay on active surveillance longer, because maybe they can modify the cancer progression a bit, like weight loss, smoking cessation, diet, and exercise. I threw in just a few words about supplements because we get a lot of questions about this. There really isn't a magic pill. I'd love if there were. There have been trials on selenium and vitamin E. That's the SELECT trial that really didn't show any benefit. Lycopene's been somewhat inconclusive. There's not a huge trial that's actually showing a benefit. Antioxidants like green tea, blueberries, curcumin, which is turmeric, again, inconclusive, not harmful. There's small studies that show some type of benefits for a variety of different types of cancer and other disease states for antioxidants. There's one trial, a Dean Ornish study, that actually showed a benefit specifically for prostate cancer with a vegan lifestyle and exercise and randomized control trial. But this is a very, very radical diet and lifestyle change. I would say, just to summarize this, there's not a pill that's going to help, but changing your lifestyle, changing to a healthy plant-based diet, limiting red meat, stopping smoking, getting to a normal BMI, and exercising is going to help not only prostate cancer, but it's going to help every element of your health. And no supplement will be more impactful than these steps. But of course, these steps are hard. It's not easy. And then this is just a list of questions that I think is good for patients to have. You probably all have thought of this already. But if you haven't, these are good questions to ask at your active surveillance follow-ups. So is the MRI changing? Sometimes physicians may assume you've been on surveillance for so long, you can read your report and you totally know it. Is something changing in the MRI? Is your PSA consistently and rapidly rising? Don't get worried about one little number that's up as long as it goes back down. But if it's consistently going up over time, you need to know it. Is the volume of disease changing? Is your grade changing? Is there any pattern 4 present? Is there cribriform? Is there intraductal? Am I following up as closely as I need to? Are you missing visits and they're important? Do you need closer follow-up? And then, of course, something I mentioned a few times is active surveillance making my life worse due to stress, or are you handling this? And there's so many different ways to get help from the stress of this. And this is one example today. There are a lot of support groups locally as well, but this is something I think you should consider while you're on active surveillance as well. And that is my email. If anyone has any questions for me, I'm happy to answer anybody. And I think we're going to take some questions now.
Yeah, Dr. Greene, thanks for a terrific presentation, and thanks for taking the time pre-New Year's Eve. There's nothing more fun than talking about active surveillance, right?
Nothing more fun. Not in my life. This is it.
I'm going to ask a couple of questions as a moderator's privilege, and then Jim will come back with some questions, and we'll just bounce the ball back and forth until we're exhausted. But your point about timing of treatment came across strong. But I wonder, for the men who fit into the very low risk category, what proportion of them are able to dodge the bullet of treatment altogether? And how does that
That's such a good question.
Yeah, how does that compare to the other groups?
So it depends on, there was a slide I showed of the different cohorts, the active surveillance cohorts. There was Hopkins, Toronto, Canary Pass, and UCSF, so all the different active surveillance cohorts. And each one of them has different variables. And that, the point I'm getting to is, it's hard to tell, right? So you can have a group of men who all fall into a very low risk category, but they can be really different. What if their initial biopsy was a 12-core biopsy versus a 20-core biopsy? What if their initial assessment took anterior cores versus not? What if they never got an MRI versus they did get an MRI? So I think the proportion of men who are in very low risk and can just avoid treatment forever, it really depends on how true that initial assessment is, because we've all known men who seem like they are very low risk, right? Micro-focused in one core. And this is the story that always stays with you, but somehow they progress to really bad cancer very quickly. And I think we all know, well, they never really had a microfocus of Gleason 3+3 to begin with. They had worse cancer that wasn't diagnosed. But that's why it's really hard to answer the question. It's hard to say, you know, if you're very low risk, what does it mean? Can you stay on forever? The average time on active surveillance is different in different cohorts. Very low risk, I think as long as you are accurately assessed, maybe you are someone who can be on 5 to 10 years. Maybe you're someone who, depending upon your age, will never need treatment in your lifetime. And that's kind of the goal. And what informs that a bit is the study I showed you in JAMA. So those men were on active surveillance for more than 10 years, you know, more than half the cohort was, and they weren't treated. So, and that was a mix of very low and low risk men. So, I mean, you can't say exactly what proportion. Very low risk, you have a chance of avoiding treatment entirely, but it completely depends on how accurate that initial assessment is.
I'm going to ask another question, then I'll turn it over to Jim. We've had sort of an ongoing discussion in the support group about men in among men in their 80s, who some of them say, you know, I've had enough. I've been followed for, I don't know, 10 years. I've had so many biopsies and so many MRIs. And, you know, I'm 80 years old or I'm 85 years old, and this is it for me. You know, I'm feeling fine. I'm just going to roll the dice. Then we have the other guy who's 83 who says, you know, I want to stay on active surveillance forever. You know, I'm 83 and I'm doing great, and I'm feeling fine. And, you know, so the question comes up in these discussions. I mean, you know, what's the right approach? Is there any magic number like age 80? And and I know the doctors talk about, you know, sort of your survival horizon, how many years you have left. And so how do you determine that? So is there anything magic about age 80? And
There's not. It depends on your comorbidities and your life expectancy. You know, so if you're an 80-year-old and you're perfectly healthy and you take no medications and you run marathons, your life expectancy is going to be a lot longer than someone who maybe has had, let's say, multiple heart attacks or multiple strokes, or even somebody who just is balancing diabetes and high blood pressure and a couple other things. So it depends on your own health. And a life expectancy calculator, and there's a lot of different ones. You can sort of plug your own numbers into that and it'll give you an answer. But if your life expectancy is maybe less than 5 years, being on active surveillance probably isn't going to really benefit you, right? Because if you've been on active surveillance for a really long time and your cancer progresses, there's not a lot of times where treatment within 5 years really benefits anyone. So a short life expectancy, I think it makes sense to stop active surveillance if you've been on it for a really long time.
Well, let me ask you just one other variation on this, which is, some of these guys, I think, worry that they're going to miss some window of opportunity if they don't get treated before they're age 80, even if they're doing fine. I mean, is there some age where treatment doesn't make any sense anymore?
It depends on your health. I think after a certain age, surgery probably doesn't make sense because, continence recovery for someone in his 80s is going to be really different from continence recovery of someone in his 70s or somebody in his 50s. And the risks of surgery at some point just might not make sense to someone. I think radiation is more acceptable at any age, but again, if you have a very limited life expectancy, you're not prolonging your life by treating your prostate cancer if you have a competing comorbidity. Does that make sense?
Yeah. Jim, why don't you take over for a while?
Okay. One of the things that I see most in the active surveillance support groups is men with Gleason 3+4 who are really struggling with this decision. Do you have a recommended protocol for these guys to analyze the situation? And what I'm thinking of here is what tests and in what sequence are going to give these guys hopefully the best answer?
Well, I think a recent biopsy. So that's the first thing. You know, if you had a biopsy a couple years ago with 3+4 and you haven't been re-biopsied, step one is get a new biopsy, find out what your volume of disease has done. Because increasingly we're realizing that the volume of cancer, how much 4 component, either percent or length, that really correlates with outcome quite a bit. So get a recent biopsy, you know, get a recent MRI, well done MRI. That's a good place to start. Recent PSA, of course, you're going to have that. You want to make sure that the pathologist is telling you and looking for cribiform. Not everywhere reports on it. So that's an important question to say, you know, to your doctor and say, you know, does pathology here report about cribiform component, yes or no? Because sometimes they don't. Do they report about intraductal, yes or no? Sometimes they don't. So get that information. That's going to be a deal breaker right there. If you find out, hey, yeah, you've got 3+4, but there's cribiform, okay, fine, so stop. It's an easier decision. And then I think sometimes genomic tests can be helpful too. You know, run a decipher and see where you're coming out on decipher. If it looks like it's higher risk than where you should be, then go for it. The other part of it though is kind of figure out how upset are you going to be if you missed your window for cure. Some people with Gleason 3+4, some patients I've known say it's really about quality of life. I'll be less upset if I miss my window than I will be if I get treated too soon and take the good years of my life away. For me, that was really impactful. It's like, wow, okay. You know, what would you rather? Would you rather get treated too soon and maybe miss out on 3 more years of great quality of life? Or would you rather get treated too late and not be cured or have to have, you know, surgery plus radiation or radiation plus longer hormones? I think that's a question that has helped a lot of patients I've worked with really get them to where they want to be, whether stay on active surveillance or leave. But the pathology for me, that really helps a lot. Get a second opinion on pathology.
Okay.
It's never wrong to get a second opinion.
Okay. You mentioned cribiform and intraductal. Could you tell us a little bit about what those are, why they're so important? And I guess I find your statement that they don't all look at that or they don't all report on that. I find that kind of shocking. So what's your view on that? I mean, my God, if it's so important, I mean, it should be in absolutely every pathology report, shouldn't it?
I mean, it should, but the truth is it's not. If, you know, if you're in a smaller place, then maybe the pathologists there who have to look at everything. You know, they have to look at breast and colon and skin cancer and prostate cancer. Maybe they don't stay up on every single thing, you know? So smaller places where you don't have a specialist in urologic oncology, some places don't. It's hard to know every single thing about every single cancer if you're the only one reading it or just in a small group. And it is important to know that's not reported everywhere. Things aren't standardized like that. They should be, yes, but they're not. So as a patient, maybe this is the most important thing I've said all night, but you got to ask these things. You got to look at your pathology report and you need to ask the question. And if people are saying, what's cribiform to you? You got to get a second opinion on that pathology because maybe they don't know either. And so what is cribiform? What is intraductal? They're just patterns of Gleason 4. So under the microscope, it's the way the cells look. It's the way the little prostate cancer glands are fusing together or forming. Intraductal was recognized a little bit more recently. It's just a different appearance. Again, it's a different pattern under the microscope, but it tends to correlate with higher grade disease. So it tends to correlate more with like Gleason 8. It behaves more like Gleason 8. Cribiform may have a genetic component to it. So one recommendation I think that was in the guidelines a few years ago was that if there was cribiform pattern, patients should be counseled regarding possible genetic testing. And the problem with them isn't that they'll just grow and get bigger. The problem is we worry that those patterns have the ability to spread, so to metastasize. I'm not worried that that cribiform 4 is going to turn into a 5. I'm worried that that cribiform 4 is going to say, I'm getting out of this prostate and going to the lymph nodes. So that's why.
Okay, thank you.
Jim, can I
If somebody is in one of the smaller places that you're talking about a second ago, can they mitigate the question of cribiform and intraductal if it's not reported by simply getting a second opinion from an expert like Jonathan Epstein at Johns Hopkins? Will that solve the problem, or at least get the right analysis? Okay.
Yeah.
All right. Howard, you wanted to?
Yeah, I wanted to dive in. Dr. Greene, you were hinting at intermediate grade, and I'm wondering, you mentioned 3+4, and some of those men go on active surveillance. But we were talking the other day, I think, about 4+3, and maybe you can address whether those men should consider active surveillance. We've heard from some men with that pattern who go on active surveillance. Is that a safe thing to do?
So in my opinion, it's not. That's based on some fairly conservative groups of active surveillance cohorts. You know, the Hopkins cohort is a very well-studied cohort that didn't have any Gleason 3+4. UCSF and the Toronto groups had a little bit of 3+4, but generally speaking, when 4 is the first number, that means there's more 4 than there is 3 in that particular core. I don't really think that's particularly safe. If you need to delay treatment, let's say you just cannot get your surgery or your radiation in a timely fashion with Gleason 4 as your primary component, that's not really active surveillance. That's, you know, life getting in the way of treatment, and I can't be treated for 6 months or a year. It just doesn't seem like it's the right thing to do. And the reason for that is other things that I haven't shown tonight, just showing that when there's Gleason 4 as the first component, men have a much higher risk of upgrading at the time of prostatectomy, of metastatic disease, of upstaging at the time of prostatectomy. So you're not kind of fulfilling that goal of active surveillance, which is delaying treatment but still having the same opportunity to be cured. You're actually delaying treatment, and then when you get treated, it's actually worse. So that's why I don't think it's a good idea. I think the data show it's not, and it's not in the same spirit as very low risk, or favorable intermediate.
Let me make clear that that some of these questions are not coming from the moderators themselves, but are coming from the audience, either
they're good questions. They're all good questions.
Either in real time or previously submitted. And this is one that comes from one of our regulars. And it has to do with high volume Gleason 6. And there was a new study that came out in November, led by Dr. Catalona here in Chicago, where he says a novel finding in the study is that high volume Gleason 6 can, you know, apparently is posing a risk comparable to some of the higher grades. And I wonder what your interpretation is for high volume Gleason 6. Can these men safely go on active surveillance? And
that's a great question.
We've had increasing numbers of these patients show up in our group. So, at any rate, what do you think?
So, I think it's that idea, that philosophy that you just spoke about, that high volume Gleason 6 is behaving more aggressively. You see that thought or the belief of that in the NCCN guidelines. And in the NCCN guidelines, Gleason 3+3, so Gleason 6, grade group 1, that's high volume, is favorable intermediate risk disease, right? Which you talk about favorable intermediate risk disease. immediately to my mind, I'm talking about grade group 2, 3+4. But you can have high volume 6, which doesn't seem to make sense based upon so many studies that haven't actually shown a survival benefit to treating high volume Gleason 6 or any Gleason 6. That haven't shown any difference in prostate cancer specific survival, overall survival, metastatic disease, again and again and again. We have these big studies showing exactly that same question, that there isn't a survival benefit. So then you have to kind of ask, well, what's different? Is something being missed? Is there higher volume cancer? Is there 4 hiding in there somewhere? But exactly what you expressed, that's the NCCN guidelines right now. And those people are favorable intermediate risk.
Of course, NCCN also was the group that temporarily redefined whether active surveillance was preferred. And it was pressure from urologists like you and support groups and advocacy groups that turned it around in 2 months, which was pretty amazing.
It was amazing.
So hooray for us.
Hooray for us is right.
But let's see here. Okay, you're a guidelines guru. So, I mean, this is appropriate. I mean, you helped write guidelines for AUA, and I don't know if you were one of the panelists on the current rewrite. And I don't know if you were, how much you can tell us about it.
I wasn't.
But you seem to be suggesting some knowledge of what the guidelines are. Now, a number of us have signed up to review the guidelines in January. Do you have any sense of where they're going? Just to put you on the spot.
Yeah, no, I
didn't you
don't
read
have
the
any sense of where they're going.
agreement?
I signed one, but I'm not spilling any beans. I'm asking her to spill the beans. So
no, I have no beans to spill. I wasn't on the guidelines
no
this
beans
time.
to spill tonight. Can
No
I
beans.
hop in and ask a few questions about imaging? Okay. We frequently hear about the increasing importance of MRI in active surveillance, first of all, in going on or staying on. But we also hear that MRI is, first of all, not available everywhere, and also a very difficult study to interpret for prostate cancer, that you really need an expert interpretation. So I guess my question is, how do you deal with some of those issues? And then after that, I want to talk a little bit about micro ultrasound and whether that's an up and coming alternative or something that patients should be asking about now.
Yeah, I think everything you said about MRI is exactly right. And I had that in my slide as well. It's expensive. You have to have a good machine. You have to have a good radiologist to read it, because it is a tricky scan to read. It's becoming a lot more common. So that's a good thing, meaning it's a lot more places. So radiologists now are being trained in reading this because of prostate cancer, and in part because of active surveillance. So that is hopeful. I do think that the different transrectal ultrasound technologies coming out are really interesting, and I'm hopeful about that as an alternative to MRI, especially for patients who can't have an MRI because of pacemakers or metal fragments, or aneurysm clipping. So I'm very excited about that. I think the preliminary data look great. But I would say, remember, with prostate cancer, it's never the wrong thing to get a second opinion. It's probably the one disease where you're expected to get a second opinion, which means, you get your diagnosis, and if it's the one time you're actually going to drive somewhere that's a high volume center and get your MRI there, get your slides overread there, it's worth it. It's definitely worth it for prostate cancer. Some things you don't need a second opinion, but I do think in prostate cancer it is. And so that's a way to get that MRI and get the slide review we were talking about earlier.
Okay, so am I understanding you correctly that a patient should both have a second opinion on have second opinion on both the biopsy slides as well as an MRI. Have it reread?
You don't have to have the MRI reread. You can. A lot of places that are high volume for prostate cancer are going to say that's their standard process, though. As everyone listening probably knows, you know, you want to go to UCSF, you want to go to Hopkins, you want to come to UVA. We say, send us your imaging. We're going to do a second opinion on your slides because it is so important to look for those components. And we want to do a second opinion on your MRI as well, unless it's been read somewhere else that, you know, super high volume MRI, 3 Tesla looks great. But that's pretty standard for a lot of academic or just really big private centers that do a ton of prostate cancer really well. That's the normal process.
We have a question from the audience that's in the imaging sort of genre. The question is really, what do you feel is best at this point? What do you feel is both most effective, and what should men use among the various imaging strategies during their AS journey?
So for active surveillance, definitely MRI. You know, I really feel it's important to have an MRI. It is very hard to be a great transrectal ultrasonographer as a urologist. Some people have a talent for it. One of my former colleagues and teacher, Katsuto Shinohara at UCSF, that man is amazing. He's just brilliant at reading the ultrasound, and most people can't read it that well. So I think getting an MRI, whole separate modality, looking at it a completely different way, is a great adjuvant test, in addition to the transrectal ultrasound, which a lot of people just don't know how to read that well, just being honest. And that's what I would recommend. I think if we're talking about staging for higher risk disease, I'd have a completely different answer. But for active surveillance, it's MRI. You don't need a PSMA PET on active surveillance, if anyone's wondering about that.
Thank you.
So in England, as Jim said, MRI seems to be, you know, more central to managing patients like us. But there's an idea that's come up there about the urologists learning to read MRIs. It sounds like from what you said, maybe a bad idea.
I don't think it's a bad idea. You just need to be taught how to do it, you know, like anything else. Or you need to do it so much that you eventually teach yourself. So I can read them fairly well now, but I've been doing it for a long time. It just has to be intentional, and you have to be taught and want to learn. It's really common in Australia too. So you're right, England and Australia, MRI is very common.
You know, I kind of dropped the ball earlier in talking about the guidelines, and we do know, and I don't think that we're giving anything away here, that the new AUA guidelines are going to deal with transrectal versus transperineal biopsies. This is another issue we have beaten to death in this group. And I noticed in your presentation that I wasn't sure if you were hinting at transperineal, or do you really still emphasize transrectal? What are the pros and cons?
I think it just depends on if the practice you're going to can do transperineal. Not everyone can offer it. And if as a patient you're willing to sort of tolerate what it involves, it definitely has a lower infection rate, no question, much lower infection rate. Some people, transperineal, they will get anterior cores. And so if that's the only way someone's going to get anterior cores, then go transperineal. It's very easily done transrectal. But, you know, if it means doing it, getting them or not getting them, I'd say get the anterior cores no matter what. Transperineal definitely takes longer. It's less comfortable. A lot of times people need some type of sedation or anesthesia. It can be done under local, but you as a patient have to be willing to put up with it. You know, it's more to go through than a transrectal ultrasound. So I don't have a strong feeling one way or another. It's very hotly debated right now.
Right.
I think the patients will actually determine this one, honestly, because doing it
yeah, the patients are divided. I mean, we know plenty of men who've had it done as an in-office procedure, and there's others who, don't want to do it that way. They want to be put out.
Yeah.
And there's debate over the pain. Well, the guys that are put out don't really know, but some of the guys who've had it say that it's not too bad. So, I mean, it's kind of like you were saying earlier about individuals, and we have different abilities to put up with pain. But at University of Virginia, do you offer transperineal?
We have transperineal, but right now we're doing it in the operating room. We're just waiting for the last little bit of all of our equipment to start doing it in the office. But we're going to have to see how patients feel about it. Some patients are really highly motivated and they want it because the infection risk is much lower. But I think we're going to have to see how people can tolerate it.
Okay. Jim, do you have something?
Okay. Yeah, well, we had a question from the audience that I can answer. What does AUA stand for? American Urological Association. It's the Professional Society of Urologists. And I don't know, Kirsten, whether you want to say a bit about that and how they generate guidelines and that kind of thing.
Yeah, no, that's who they are. There's a really large patient advocacy arm of the American Urological Association, and they're generally speaking are patient advocates who are on the guidelines as well to help bring perspective. The guidelines at AUA are a little bit different from NCCN. NCCN is expert opinion. AUA actually does essentially like a statistical analysis of all studies in a particular area or focus, and especially looks at randomized controlled trials, levels of evidence. So how good was the study? Was it the best, the top quality study? Was it not so good? Was it low level? Is it just expert opinion? So they end up with slightly different recommendations depending upon something that's provable in the literature. That's why sometimes you'll say, well, how come NCCN is so specific in giving all this information and AUA is a little bit more wishy-washy? And it's because it's a little bit more evidence-based in a more structured way. Not saying NCCN doesn't use evidence as well, they do, but it's just a different type of analysis for AUA.
Thank you. I think the adoption of active surveillance by newly diagnosed patients in the United States is now running about 50%. In some other countries, specifically Sweden, it's as much as 90%. Do you want to comment on why the difference and what are we doing right or wrong in the United States?
I don't know the healthcare system in Sweden well enough to say. I don't know if it's that their doctors say this is what you need to do. You don't get all the different options. I do know just from my personal experience with patients that if I'm a second or third or fourth opinion, at some point in time, that patient has been told by someone, well, if it were me, I would do surgery. So I think, in the US, we do have a little bit more of that individual opinion where your doctor is telling you, well, I think you should do X, rather than saying, here's the options, here's what's recommended. Let's talk about what's important to you. Let's make a decision together, which is shared decision making. It could be that in Sweden, they're just like, listen, active surveillance, this is what we're supposed to do. Or there could be metrics as well. Some places, speaking with Caroline Moore from London, and I think she had mentioned that only a percent of people they treat with HIFU, for example, are allowed to be very low risk. So if you make it a very bad thing, either from a structural standpoint or from a reimbursement standpoint, to overtreat very low risk men, I think we would see a much higher adoption of active surveillance.
Well, if I can follow on what Jim was asking too, I've been talking a lot to Dr. Braca in Sweden and to Dr. Klotz in Toronto, because I write about this stuff, and I was preparing an article about Sweden, and the point that they make is the incentives are different for doctors in the United States. for Dr. Braca in Sweden, and he's chairman of their guidelines committee for Sweden. They're paid the same whether they do surgery or they do radiation or they put somebody on active surveillance. And of course, in the United States, we have some mini examples of that, especially academic centers and in the VA hospitals. The incentives are different, but the incentives in the community are such that the doctor may lean towards surgery, recommending surgery strongly because he or she is going to get paid more. But and there's other factors too. Klotz says that there's different cultures for surgeons depending on where they practice and where they were trained. And so the Canadian and Swedish doctors may be less surgery happy or inclined. And there's other factors like that, but maybe you can comment on incentives.
I mean, I think that's a really cynical way to look at it. It might be true. It also is equally true that, things like HIFU, that everyone's very excited about and heavily marketed and are highly reimbursed and are cash only. People either want it and seek it out rather than active surveillance or recommended it. But the other side of that is, prostate cancer changes really quickly. The recommendations change every couple of years. There's a different drug, there's something else. Now we're calling it low risk. Now we're calling it unfavorable intermediate. Oh, wait, no, now it's back to low risk and it's preferred or it's not preferred. I mean, if you are someone who is a general urologist and you do everything, maybe you're not staying on top of the latest recommendations. Maybe you've never heard cribiform, right? Because you're also doing kidney stones and slings and pediatric urology and doing all these things. So, on the cynical side of it, we're all out for money and we're bad people and we don't really care about our patients. I don't actually believe that's true. I think more likely than not, people do really care about their patients and they really do want the best for them. And they're worried about them. They think, if it were me, I really would have surgery for high volume, low grade prostate cancer. I don't think Dr. Catalona, for example, I don't think the motivation for that paper that you mentioned earlier about high volume, low risk prostate cancer is him wanting to make more money from radical prostatectomy, right?
Well,
motivation is he wants to find the truth. He wants to take care of men. He doesn't want people to die from prostate cancer. I think there are probably a lot of people who feel that way.
He individually has changed a bit in the last 10 years in terms of active surveillance. He used to be the debating partner against Klotz for many years, and Klotz almost always won the debate, and in fact, in the long term, seemed to have won the debate about active surveillance. And Catalona, I think, has changed his practice. Not to dwell on him individually, and I don't think he's acting out of greed myself.
Absolutely not. And that's why I used it as an example,
No,
because it is easy to go down that pathway of saying, oh, it's just surgeons. No.
I didn't want to suggest that, but the incentives thing gets dicey. There's another aspect to it too that Dr. Braca from Sweden brings up, which is the differences in the medical legal system. Our doctors, in his view, are doctors in the US more likely to be sued if they don't follow guidelines closely. And a seemingly low risk turns into a raging tiger of disease. He said in Sweden, if he blew a diagnosis that way, the worst that would happen would be he would get a slap on the wrist. We have different cultures in terms of the law. Maybe Jim has something to say about that as a lawyer.
Yeah.
No, I don't, Howard. But
Yeah, go ahead.
I think it's pretty clear that we have a history in this country of an epidemic of overtreatment of this disease. That overtreatment has ensnared many of us who have suffered unnecessary radical treatment that has drastically affected our quality of life. In fact, it was so bad that the Preventive Services Task Force in, I think, 2012 came out with a recommendation of don't do PSA at all. You're hurting more people than you're helping. They've revised that, of course, as we know, I think in 2018. And one of the reasons that they cited for that was the increasing prevalence of active surveillance. Do you have a
It's also
view?
because the data they based the initial recommendation on was wrong. I mean, the PLCO trial was contaminated with, I mean, it was based on the wrong data, and they completely ignored the European study. So, yeah. I agree with what you're saying about an epidemic of overtreatment, no question, but that U.S. Preventative Service Task Force recommendation was based on a very flawed study that then was found to be even worse than we thought, and a lot of men were not offered the opportunity to screen.
I know that the docs and scientists involved in this argue over the studies and the statistics and that kind of thing. But from a patient perspective, the real difference, I think, is active surveillance and how doctors are talking to patients about this disease. Do you have a view of what's the right way to do it, or what the appropriate percentage might be for newly diagnosed men going on active surveillance? Or
I think if you are very low risk, my opinion is 100% is the right number on active surveillance. If you're very low risk, worst case scenario, you can still get 2 years out of it. So that's my opinion based on data. I think the right way to do it is not to deny anyone the right to be screened with PSA, though, because again, this is obviously a hot button topic for me and every other urologist in the world about the PSA screening, because we saw what it did to men, which was, when you look at the curves, the death from prostate cancer, the diagnostic rate, people were actually really harmed in those years that they weren't offered prostate cancer screening at all. And so the right way to do it, in my opinion, is give men a choice about prostate cancer screening. Don't force them to do it. Don't tell them they can't have a PSA. So everybody gets to decide and ask questions. And then if you get that diagnosis, get a second opinion on your slides, get an MRI, get someone else's opinion about it. And if you are very low risk or low risk, active surveillance is the right way to go, at least for some period of time. Maybe not forever, but for some period of time. And if it does nothing else, you get to enjoy a little bit more quality of life, but you get time to really think about your treatment options and make the right choice for you. So I think that's the right way to do it.
Are there any other?
You can ask me again about the U.S. Preventative Service Task Force. No, don't.
I'm sorry, what?
Nothing.
No,
I'm just laughing. You got me all fired up.
I see that.
But what else can be done if you have any ideas to persuade more men that active surveillance is the right choice, or is a safe choice anyway for them?
Talk to people. Just don't take one person's opinion on this subject. Whether you get a second opinion, you can do virtual second opinions. There's lots of places all across the country that offer like a telemedicine second opinion visit. So you don't even have to go travel to anywhere new, but just talk about it. Go to support groups, get other people's advice, get as much information as you possibly can. Don't just take one person's word for it. Even if that's me, even if my patients are watching, don't just believe me, get another opinion as well about active surveillance. No one should ever be offended if you have newly diagnosed prostate cancer and you want a second opinion. They should never, ever hold it against you or feel like it's the wrong thing. So just keep talking about it.
What do you see as the role of support groups in active surveillance? Do you think that that they're helpful? Do you think that newly diagnosed men should all seek peer support? How do you feel about that? Is that part of the solution to the problem?
I think they are helpful. I think they're really helpful. I mean, it's great to not feel alone. And no matter how close you might be to your doctor or your APP or the care team, it doesn't take the place of a support group. You can just talk about things more personally. There's no time element to it. You can just get somebody else's life, you know, how they handled it and how they got through it. So I think it's incredibly important. I think everyone should be offered a support group, but realize talking through problems isn't everyone's cup of tea. And so I don't think it can't be mandatory. I think it's incredibly helpful, and it's great if you have access to that. But
By the way,
some people don't like to talk about their feelings.
Yeah, Dr. Greene, are you willing to stick around a little bit longer?
Sure.
Okay. You know, Jim, we should be mining the questions that are coming in. And here's a question that used to be used to come up a lot more often a couple of years ago. And this is whether contrast is absolutely necessary for the MRI. There used to be a lot of concern about gadolinium in particular crossing the blood-brain barrier and not being fully excreted from the body. And
Yeah.
you know, have things changed with that? You know, is it, or you know,
Yeah.
where do things stand with that?
That's a good question. So there are newer gadolinium agents that are a lot less toxic, and they don't stick around as long. One of the concerns as well was that men with bad renal function, they would get the systemic fibrosis syndrome from the gadolinium. So there are new agents now that are a lot less toxic, which is great. The other thing is I've seen quite a few articles and spoken with our radiologists at UVA as well about just biphase MRI. So not necessarily multi-parametric, but biparametric, which is without contrast. So you can still do diffusion weighted images. You just can't do, you know, T2 with gadolinium. And there are some really compelling data suggesting that it's just as good. So,
but that's
the consideration.
That's not widely available, though, right?
I get, you know, widely available. It's a good question. Having just been at academic centers, it's available at academic centers, but it might not be available everywhere. It's certainly a question to ask. I would say if you can get gadolinium, meaning you don't have a severe allergy, there's no real contraindication, it's great to have a multi-parametric, you know, triple phase MRI. I wouldn't avoid it intentionally if at all possible. But if you just can't have gadolinium, the allergy is usually the real reason, like severe allergy. But also if you are on dialysis, potentially, you know, there is a little bit of a risk with that as well. So get the contrast if you can, but if you can't, biparametric may be okay.
You know, another major concern of this kind of a group is, you know, the overgrown prostate, and you know how to deal with it and when to deal with it and what's the best way to deal with it. And do you have any suggestions for the peanut gallery?
Just having a large prostate? Is that the question? How to deal with just a large prostate that's causing symptoms?
Yeah, you know, they're up 10, 15 times a night or even an hour, right?
Yeah.
You know, what's
I have some suggestions for this. Yeah, okay.
Yeah.
So if you actually have a large prostate and you know the volume of it, or if you have a median lobe, which is that extra lobe of the prostate that kind of sticks into the bladder and acts like a ball valve, and you're not emptying your bladder and you've had a flow rate and you've had a post-void residual, and that's really the problem, then an alpha blocker like Flomax is a really common one. So that's one. That's going to help open up the prostate and make your stream better. The second thing you can add is something like finasteride or dutasteride. That's going to shrink your prostate, but remember, it's also going to cut your PSA by half, which you have to remember on active surveillance. You need to know if you're taking finasteride and your PSA is low or not. So that's kind of maximal medical therapy. The other thing you could potentially add in, the third thing to try, is low-dose daily Cialis, which I'm sure everybody's listening is like, yeah, we know this, but that can improve erections, but it can also help with the lower urinary tract symptoms a little bit as well. Stop drinking 3 to 4 hours before bedtime if getting up at night is a huge problem. So limit your fluid intake. Caffeine makes everyone's bladder go crazy as we all get older. And if you've had a large prostate and it's causing thickening of your bladder wall over time, your bladder is going to be more temperamental and more irritable. That's kind of how you think about it, like a grouchy bladder. And the caffeine just makes bladders just act badly. So cut out caffeine. I know that's miserable to do, but it really helps with that overactive, urinating frequently kind of bladder. And then the last thing is, if you've done all these things and you're still up a lot at night, specifically at night, and you're getting up every couple hours, you need to get checked for sleep apnea. Because sleep apnea will actually change the pH in your blood because you're not taking deep breaths. And that will trick your brain into making you feel like you need to urinate and wake you up to pee. But you don't actually have to pee, you have sleep apnea. So a lot of men go get a CPAP and they're like, holy cow, this is unbelievable, I'm sleeping through the night. These are my recommendations.
Let me bring you back to active surveillance. Another question from the audience. Can you speak to how a known germline mutation, such as Braca, impacts the decision to enter or exit active surveillance?
That's an amazing question, and we debate that all the time. So a known BRCA mutation, BRCA2 especially, is associated with developing prostate cancer. And we know that if you have a lot of first-degree relatives with breast cancer, ovarian cancer, and prostate cancer, we always think, you know what, we should do some genetic testing for this. The question, though, is if you have a BRCA mutation and you're very low risk, does that mean you can't do active surveillance? And it's not clear. I would say it argues for a close follow-up, much like the information I showed about African-American men. It's a risk factor, but I don't think it excludes you if you're in a very low risk or low risk category.
Gotcha. Here's another one.
Definitely watch more closely for those men. Get your MRIs, get your biopsies, get your PSA, follow closely.
Here's one from the audience that we hear stories from men diagnosed as Gleason 6 who opted for surgery, after which pathology identify higher grades of prostate cancer. This leads to anxieties about going on prostate cancer. So I would take that and add to it. You hinted at what we in the business call anxious surveillance. So what can be done about it? And we've had meetings about it, and we've had other speakers comment. But I'd like to hear your perspective on, first of all, this image of somebody on Gleason 6 later being discovered to having a more advanced cancer, and the anxiety this causes in other guys who are on active surveillance. So what can be done to address this anxiety?
It's a good question. About a third of the time, at the time of pathology, there is upgrading for everyone because you have the whole prostate to take a look at. So if there's just a little smidge of Gleason 3+4, it's going to be called 3+4, not 3+3, right? So that's the first thing to realize, is the volume of 4 could be very, very low. The second thing is, and I feel like I'm a broken record, so you guys are, I guess, and I'm sure everyone can guess what I'm going to say, anterior cores. So take anterior cores. If you've only had the back of your prostate biopsied, you're missing a really important spot. So, and I will tell you, at UCSF, that's what we did. We always took anterior cores. And so the whole prostate was biopsied. It's not the same thing everywhere. Not everybody does it. Not everybody believes in it. I think it's more of a West Coast paradigm, not so much of an East Coast paradigm. But 20% of the time there's cancer there. And so the answer sort of to the problem, which is, well, I've been told I have 3+3 disease and I just had a prostatectomy and it's 3+4, and how could that possibly happen? That could happen to 1 in 5 men. 20% of the time there's prostate cancer in the anterior zone that's not getting a biopsy. So my solution to that is, get an MRI, because if you have an MRI and it shows cancer in the anterior zone, the MRI fusion biopsy is going to make your urologist biopsy that spot, right? So you're obligated because it's MRI fusion targeting. And then the other thing is just make sure that it's included on your biopsy otherwise.
Yeah, something else that I've noticed increasingly is we're encountering men who 10 years, 15 years, 16 years into active surveillance, no prostate cancer is found again. Their PSA is stable. Their MRIs show nothing. And it's been suggested to some that there may be, well, and by Dr. Klotz for one, that this could be a spontaneous remission. Do you buy that theory?
No, I thought you were going to say something like it was a misdiagnosis at the beginning, because you figure if people have been on it for like 15 years and there's been a grade migration in prostate cancer and sort of a reclassification of what we call 3 and what we call 4 over time, if someone were to look back at that original sample, would they agree it was Gleason 3+3 at all? Or would they say, you know what, that's actually not, it's atrophy or it's something else, or it's atypia? So,
well, I surprised you. I took it the other way.
Yeah.
What about
spontaneous regression? No, I don't really buy it. But it also could be so small that it just isn't growing at all. If it's a tiny, like a needle in a haystack for real, like a tiny little bit of prostate cancer.
Well, we've heard this song a bit. Somebody's quoting Dr. Klotz saying that all men on active surveillance should take vitamin D, statin, and metformin. Can you comment on that? And
So
he says,
D.
thanks for your terrific presentation. So,
my pleasure. Thank you for saying that. So I think vitamin D is not going to hurt you. There's nothing dangerous with that. So taking vitamin D is perfectly fine. Taking a statin is really important for most men, and certainly it's going to help heart healthiness, which is great. Taking metformin, that's where I'm going to disagree a little bit. So metformin does have some anti-cancer properties associated with it, but if you are not diabetic and you're taking metformin, you could have very, very low glucose blood sugar, right? And if you have really low blood sugar, you could have a seizure, you could pass out. There's some really seriously bad things that could happen to you. The other thing is metformin can be hard on kidneys. So if you don't have great kidney function, you could be hurting your kidneys by taking metformin off label. So I think if you're diabetic and there's a reason to take metformin, or maybe you're pre-diabetic, and this is going to help you in a different way, and you can you're monitoring your glucose, that's one thing, but just taking metformin off label for all men, I worry a lot about that. Kidney function wise and your sugar, yeah. Hypoglycemia is not anything to mess with.
well, I hear metformin is great for rats who want to live longer lives. So.
But you know what also is, you could make the argument about caloric restriction, right? Like there's something that's safe that you can do. It ties in with getting you at the right BMI. There's all kinds of studies about caloric restriction and rats that live longer. So don't, yeah, metformin's a dangerous one.
I think it's coming up to, yeah, go ahead.
I've got just one question from the audience. We hear Gleason 6 called indolent. What does that mean? And can Gleason 6 progress or not? Or
That's an awesome question. So indolent means just slow growing, not dangerous. And can it progress? Yeah, it can. I have no other way to explain how Gleason 6 is there, and then I biopsy a few years later and there's Gleason 7. So I don't think that it's Gleason 6 that spontaneously, I think it's Gleason 6 that progressed to 7. I don't think it's Gleason 6 in one spot and then a whole new sprout of Gleason 7. I do think it kind of goes stepwise like that. And that's why the repeat biopsies are necessary over time, not every year, but you want to catch it when it goes from 6 to 7.
Well, let me throw this at you from Dr. Klotz and Dr. Egner, who've been speakers here and have talked about this. And I hope I'm getting this right, but I think that what they're saying is that Gleason 6 never metastasizes. So you don't buy that either.
It depends on your experience, right? If you've had a patient where Gleason 6 is metastasized, then you know it does. I will say I've seen it happen in one patient of mine and one patient of a colleague's, and that's been over what I've been in practice now 15 years. And so it's thousands and thousands and thousands of patients. So I've seen it happen twice. So for me, I can't say it doesn't happen ever, but I think it happens incredibly rarely. And, you know, when you look at the trials, the active surveillance trials, people with very low risk prostate cancer, you follow the trial, you know, this is published, anybody can read it, 1 to 2% of patients over many, many years have metastatic disease. So.
Well, I know we promised to let you go at a quarter to, but maybe you had a few more minutes.
More time.
Because there's a really good question.
You're gonna have to buy me some champagne though, because it's almost New Year's Eve. So.
Yeah, we'll send it with the party hat, I think.
Okay.
But
and a t-shirt.
Okay.
Yeah. How, you know, there's a lot of change I've seen with this. I've been on active surveillance for 11 years, and like a lot of guys in the beginning, I had annual biopsies. I felt like a pincushion.
It's terrible. We don't do that anymore.
Yeah, well, but you know, then I switched. Well, I had no problem with my doctor. He, you know, that was the protocol, and I accepted that. Then I switched after 5 years to somebody else, and his approach was every 2 years. Yet, you know, Dr. Klotz up in Canada is saying 4 to 5 years is what makes sense as an interval. So what's your assessment of intervals?
I totally hear what you're saying. I've kind of lived through what you're saying in terms of biopsying everyone. It has to be every year. And it's just been a learning experience, you know, seeing active surveillance become a commonplace treatment option for patients. We were so careful in the beginning and having to biopsy people every single year. I think somewhere in between is probably the right way to go. And early on, you're going to have closer follow-up and more frequent biopsies. I'm a firm believer, probably again because of how I've been taught, that you need a biopsy at 1 year. And that's to make sure that that first biopsy was right. But after that, I think it's very reasonable, you know, use MRI, follow your PSA. As long as everything is completely stable, delaying your next biopsy for 2 to 3 years is reasonable. And then the longer you're on active surveillance, I mean, you've been on for 11 years, that's amazing. You've seen that the disease is very stable. So maybe you don't need the same intensity as someone at the very beginning of active surveillance, the longer you've been on it. You know, you kind of get a sense of safety. And so every 4 to 5 years later on, if things stay stable, it's reasonable because we've already proven in an individual person that their cancer is more indolent. But I don't think, I wouldn't say, oh, it has to be 5 years. You know, like you're a newly diagnosed patient, I just biopsied you at 1 year and now next one's at 5 years. I think it has to be tailored to the person, because if that PSA changes, you gotta act.
You know, I'm certain we can go into the new year with this, you know, but I don't think we should do that to you. So Jim, any final thoughts or questions?
Well, at the risk of opening a can of worms, the goal of active surveillance is to delay radical treatment. what do you see on the horizon for focal therapy, and where does it fit as being either curative or sort of an extender of active surveillance, perhaps, and avoiding, harmful radical treatment? Where are we going with this? I mean, is there hope out there for less harmful treatment?
I think there is hope. I think focal therapy is really interesting. It's been around for a long time, and hopefully these sort of newer generations of focal therapy approaches are going to be what we need to really just get rid of a focus of tumor. I don't think whole gland ablation is going to end up being any better than some of the more conventional things realistically. But I think in some men, they have a focus of 3+4, and maybe some men, they have just one spot, right? Just one of 4+3. And so for intermediate risk, and it really is just one area, ablating that spot and then kind of being on active surveillance again, that would be a win. I think that would be fantastic. The question then becomes, what do you do for follow-up? Are you back to the regular PSAs and MRI and biopsies? Is that okay? Or do you just want to be done with it? I worry that focal therapy is not going to make people totally done with it. Like, I'm cured, I'm finished. But I think what you mentioned of it, is it a way to sort of reset active surveillance for people who progress on grade and a focus? It might be, and I'm very hopeful about it. It would be wonderful if I never had to take out another prostate ever again because there was something better. I mean, that's the goal, right? That's the goal.
That's the goal. That's the goal. I hope I see it in my lifetime.
I hope I think that's a great way to end it, and let Dr. Greene finish her New Year's plans and watch her mailbox for her champagne from the grateful men of AnCan. I think maybe there's a few announcements. Should mention that there's a program on January 31st. Remember, it's close to Valentine's Day, and the program is Sexual Dysfunction. It's a webinar with Dr. Rachel Greene, and it's not just for prostate cancer, but it'll address issues that apply to prostate cancer as well as other diseases. And there will be a video available of this. And I don't know that we have anything else. We've kept you past your bedtime. So
Dr. Greene, thank you so much for your presentation. It was really fantastic, and it's been very pleasant to go back and forth with questions and answers with you, and I appreciate your graciousness and your responses.
Well, and let me remind the audience that Dr. Greene may have done something dangerous because she offered to answer your questions. So feel free to send her an email. Maybe Dr. Greene, you could put that into the questions, or we can include it with the follow-up material. Either way.
So, yeah, Dr. Greene, this is Rick Davis, and I want to come back on the champers because this is important. This champers, right? So I just want to tell you, I just want to tell you that last year we did surveys for all of our prostate cancer and for active surveillance alone, and we wrote them up into posters. And poster was accepted at ESMO. It was accepted at AUA, but we deferred for a year because we wanted to do the poster in person. And I'm really proud to say we got accepted combining both surveys at GU ASCO. Now, if you happen to be attending any of those, I'm good for a glass of champagne for you. Okay?
I will be at GU ASCO, and I'm going to hold you to it.
But watch out, it gets a little tipsy after that first glass.
Yep, it's a deal.
Not to mention a t-shirt or a sweatshirt that will be coming your way.
Fantastic.
Yeah. more to
Thank you.
come on that. So, shall we wish everybody a happy new year and a better one? And yeah, and
Happy New Year.
yeah.
And we'd love to have you back again sometime.
Oh, thank you all so much. This was so much fun. Thank you very much. The questions were amazing, and I had a great time. So thank you so much for letting me be here with you tonight. And Happy New Year to everyone.
We had so many left over. But at any rate, we're going to let the dogs loose. We'll see what happens.
Okay.
Thank you.
All right, we'll be
Right,
back
good
in
night.
touch with you. Thanks, Kirsten.
Okay. Bye.
Good night.
Bye now.
Bye. Happy New Year.